This conference will now be recorded.
Good morning. I'm starting with topic abdominal compartment syndrome. Introduction. Intra-abdominal pressure is the steady state pressure concealed within the abdominal cavity. Normal intra-abdominal pressure is 5 mmHg. Intra-abdominal hypertension is consistent increase in intra-abdominal pressure value higher than 12 mmHg without any organ dysfunction. That is intra-abdominal hypertension. ACS, abdominal compartment syndrome, is defined as a sustained intra-abdominal pressure more than 20 mmHg with or without abdominal perfusion pressure less than 60 mmHg, that is associated with new organ dysfunction or failure. Intra-abdominal pressure more than 20 mmHg associated with organ failure, organ dysfunction like renal failure, hepatic dysfunction, elevation of bilirubin, liver enzymes, rise of ALP, risk factors associated with abdominal compartment syndrome. Diminished abdominal compliance, that is loss of muscle integrity, laxity, so reduced abdominal compliance. Acute respiratory failure, especially with elevated intrathoracic pressure, abdominal surgery with primary facial closure, in this associated with laxity of the abdominal muscles. We exercise the fascia and muscle and then we try to close it, leads to tension closure, reduction in the abdominal space. So there is a chance of abdominal compartment syndrome Major trauma, multiple organ injuries, burns, which cause scar formation, deep burns, fourth grade burns, which associated with formation of scar, so that loss of skin elasticity and muscle integrity, reduction in the free movement of abdominal muscles, reduce the free space, prone positioning. These are all abdominal causes, abdominal muscle skin causes. Increased intraluminal contents, like contents in the bowel, gastroparesis, there is reduction or absence of peristaltic movements, ileus, colon pseudo obstruction, this is called Ogilvie syndrome, increased abdominal contents, hemoperitoneum due to any injury to the organ or vessel, pneumoperitoneum due to penetrating injuries or through the perforation of gastric contents, stomach, small bowel, large bowel, whatever, due to trauma, ascites, liver dysfunction, risk factors associated with capillary leak or fluid resuscitation, acidosis, hypertension, hypothermia, multiple transfusions or massive transfusion protocol in hypovolemic patients, coagulopathy, massive fluid resuscitation with crystalloids, like RL and NS, oliguria, reduced renal perfusion leads to the decreased urine output, which may lead to thought space loss, increased thought space loss, sepsis, major trauma or burns, intra-abdominal pressure, interpretation, which is normal, which is abnormal, zero to 5 mmHg, which is normal, 5 to 10, commonly seen in ICU patients, 12 to 15, intra-abdominal hypertension, which is grade 1, 16 to 20, grade 2, dangerous intra-abdominal hypertension, begin non-invasive interventions, 21 to 25, grade 3, impending abdominal compartment syndrome, strongly consider decompressive laparotomy, grade 5, more than 25 mmHg, abdomen compartment syndrome established, organ dysfunction develop, physiological insult, a critical illness, ischemia, reduced blood supply, which provoke inflammatory response, ischemia due to any cause, due to hypovolemia, initially give fluid resuscitation, excess fluid resuscitation leads to bowel edema and third space loss, which increase capillary leak, tissue edema including bowel wall and mesentery. So these are all together increase intra-abdominal pressure. This intra-abdominal pressure further compromise the blood supply. So this cyclical process this insult occurs at intra-abdominal pressure usually more than 12 mmHg. If pressure more than 20 mmHg, this is already established physiological phenomena. Pathophysiology system wise, increased intra-abdominal pressure causes upward displacement of the diaphragm. Which reduces the free movement of the diaphragm, decrease lung volume and compliance, increased airway pressure, results increased peak airway pressure, ventilation perfusion mismatch, hypoxia, hypercapnia, respiratory acidosis, barotrauma, pulmonary edema and infection, these are all due to decreased lung compliance and volume. Ventilation perfusion mismatch leads to hypoxia, oxygen carrying capacity decreased, oxygen carbon dioxide exchange lost, so carbon dioxide retention increase, which leads to respiratory acidosis, increased pressure in the lung causes barotrauma to alveoli and lung parenchyma, so that there is increased permeability in the lungs, capillary leak leads to pulmonary edema, accumulation of fluid, which attracts the infection. when intra-abdominal pressure reaches 25 mm Hg, so that there is an increase in end respiratory pressure to achieve a fixed tidal volume. Modest increase in intra-abdominal pressure exacerbate lung injury. Inhalation injury or respiratory distress syndrome, ARDS, acute respiratory distress syndrome. Next system is cardiovascular system. Increased intra-abdominal pressures cause compression in the vena cava, so that reduced venous return elevated intrathoracic pressure, which also cause multiple negative cardiac effects. Decreased cardiac output, decreased cardiac index, increased right atrial and pulmonary artery occlusion pressures, decreased ventricular compliance, increased systemic vascular resistance, decreased systemic delivery of oxygen, due to pressure in the inferior vena cava, decreased venous return, peripheral pooling of the blood, increased pressure in the arterial system, to increase cardiac output and venous return. So peripheral vascular resistance increase, due to increased intrathoracic pressure, which causes pressure on the cardiac function also. So there is reduction in the free space and reduced ventricular compliance. and due to pulmonary edema, pulmonary arterial pressure increase. So right atrial pressure also increase. Next system is gastrointestinal system, GIT. Increased intra-abdominal pressure causes compression of the mesenteric vasculature. Decrease in splanchnic perfusion. Mesenteric venous hypertension. Decreased hepatic arterial flow. Results severe intramucosal acidosis due to decreased lactate clearance, due to reduced peripheral perfusion, decreased blood supply, decreased oxygen supply. So there is increase in anaerobic metabolism due to hypoxia, causes increased lactate production, so there is increase in acidosis, intestinal edema, visceral swelling, increased intestinal permeability, and possible bacterial translocation. Usually bacteria absent in the stomach and small bowel, usually present in the colon. Due to increased permeability, the colonic bacteria enter into the peritoneum, abdominal cavity, and they may translocate into stomach, small bowel, cause infection, which is called secondary bacterial peritonitis. Usually seen in ascites patients. renal system, due to increased intra-abdominal pressure, compression, of the kidneys, and reduction in venous outflow, reduction in arterial supply, increase in pre-renal vascular resistance, shunting out blood from cortex to medulla, decrease in glomerular filtration rate, decrease in renal plasma flow, decrease in glucose reabsorption, decrease in urine output, ultimately leads to renal failure, nervous system, elevated central venous pressure, increased internal jugular pressure, cerebral pooling, and increase in intracerebral pressures, decrease in cerebral perfusion, cerebral edema, anoxic brain injury. Next class, I will continue with next types, causes, and management. Put your attendance in the chat box. Thank you.